Here, last section of pharmacology related to the endocrine system, we're going to focus on anti-diabetic medications. And one thing I am going to say to you is I know there was a lot of material across the entire endocrine system, but really the medications that we've talked about in the lectures and the topics that we've talked about in the lectures are the ones I really want you to focus in on. Don't get hung up on the ones that we have not covered. For my purposes, you won't see those again. So we're going to talk in this section specifically about diabetes and the medications that we use to help control diabetes. Objectives for this last section are that you can identify the symptoms that go along with insulin deficiency. You can describe basically the two types of diabetes. You can tell us how insulin is used in the treatment of diabetes, and describe the mechanism of action of something called insulin sensitizers. So if we start out with this, basically what is diabetes? And the quick in a nutshell description would be it's you don't have enough insulin in the body to metabolize the circulating glucose. Insulin made by the pancreas is required to bind with glucose so that the body can metabolize it. And if insulin is not available, the sugar, glucose, just keeps circulating and circulating and circulating around in the body system. Symptoms that you typically will see of this would be glycosuria, which is increased sugar in the urine. And as a result, you see polyuria, excessive urination, because of the increased sugar in the urine. You see polydipsia, which is thirst, and dry mouth. So those are the things that you'll see people will come in first, type of complaining about with their symptoms. And one of the signs that we'll often get is a fruity odor to their breath as they're speaking to us. And again, that's that increased volume of glucose that's going around in the blood supply. Type 1 versus type 2. We're going to spend a little bit of time talking about this distinguishing between the two types of diabetes. But no matter what the type is, the symptoms are the same. Okay, so the symptoms overall are the same. Treatments will vary, though, depending on the type of diabetes that someone has. So type 1 diabetes mellitus is really, it's an autoimmune disorder in which the body produces antibodies against the cells in the pancreas. So basically the body almost destroys its own beta cells in the pancreas. And as a result, the body no longer produces enough insulin. And since it's not producing enough insulin, levels of sugar in the blood rise. Because, glucose cannot get into the cells. So you end up, glucose doesn't go into the cells, so now it ends up being broken down into, body ends up breaking down proteins and fats for its energy sources. When the body breaks down fats, we get a circulation of acetone happening in the blood, and this forms ketones, and that's where we call it diabetic ketoacidosis. The ketones that you see in the urine or in the blood are the result of the body starting to use protein and fat for energy source because it can't metabolize the glucose. So those are the typical things we will see in a type that are related to a type 1 diabetic. Now in type 2 is a little different. We're not really always sure of the cause of type 2 diabetes, but we know that it's characterized by the failure of target tissues to respond to insulin. And when we're saying target tissues, we're talking about skeletal muscle, liver, and adipose tissue. So that's what we're talking about. We're talking about like target tissues. So the tissues are unable to respond to insulin, and you're getting insulin resistance. There's a number of factors that can contribute to the development of type 2 diabetes mellitus, and these include genetics. If parents had it, grandparents had it, you're genetically predisposed to developing it. We also know that obesity, people who are obese are at high risk for developing this resistance to insulin, that where they cannot use it, they cannot respond to it, and so they don't have enough insulin coverage for the circulating blood sugar, the circulating sugar that's in their blood. So we've been talking a lot about insulin. Where does it come from? Well, of course, you make it in your pancreas, but if you're not making those, where else can we get it from? Sources originally were from pigs or from cattle. So we got it from the pancreas of pigs or cattle. Really today, though, for the most part, most of our insulin is produced through recombinant DNA technology. So we're producing it in a laboratory setting. You may have heard the term humulin insulin, and that's a recombinant DNA technology that produces an insulin that's basically the same as that produced by the human body. It comes in many different forms, or many different, I should say forms, but many different onsets and durations of actions. So there's a variety of insulins out there, and they vary on when they will start acting in the body and how long they will act in the body. So how much insulin do you give? Or what's the dosage of insulin? It's usually ideally given somewhere 30 to 60 minutes before meals. There is an exception. There's some short actings that can be given as soon as 15 minutes before meals. So you want to administer the insulin before eating so that the insulin is there circulating after your body consumes the glucose. There are some long-acting ones that are delivered just once a day and once in the morning, and then that'll give coverage for all day long. It's very variable, and with close blood glucose monitoring, some people use a combination. They may use a long-acting insulin and then use periodic coverage throughout the day to adjust according to their glucose levels. Typical dosages can range anywhere between 20 and 60 units a day. However, people who develop resistance to insulin can sometimes require like large dosage, 300 to 500 units a day. An alternate therapy that we also see being used for delivery is that of insulin pumps, whereby small doses are given continuously throughout the day via a pump that a person wears, and it also has the ability then, if their sugar does elevate, to give a bolus of the medication, of the insulin, to bring the sugar down if their level does go up. I talked about how it can vary, how insulin can vary throughout the day, There's also other things that will influence it. Um, you know, things like colds and stress will increase the glucose level. Exercise can actually lower the glucose level because you're burning the sugar off. Um, Medications can change glucose levels, and allergic reactions, you know, um, can even cause to say, okay, now we're having we can have allergic reaction to insulin, so it'll actually change the type of insulin we've got to give. So we've kind of got to keep, it's a balancing act as to how much you need and what type you need, and requires, just close, continuous monitoring by physicians, as well as a lot of education of our patients so that they can effectively manage their insulin needs and their hyperglycemia. The typical adverse effects that we see with insulin, the first two are we may see some blurred vision and hypoglycemia. Too much insulin, the blood sugar goes too low. When you get that low blood sugar, there's a number of things that you will see. You will see hunger, actually. Not enough sugar, you're going to get hungry. Headache, fatigue, anxiety, nervousness. And these are kind of progressive because after the blood sugar goes low enough, then you will start to see confusion, and you may even see paresthesia, some loss of feeling. So triggers and points that need to be instructed with patients, that if they're feeling hungry, if they start to get that headache or tired, they need to check their sugar and they need to react, because it is a progressive and it will continue to get worse. It won't get better. Generally, it's funny because we say, well, some of the signs of hyperglycemia are similar to those in hypoglycemia. Well, personally, I'd rather go and give them the sugar source, eat some sugar, have it not do anything and find out it's hyperglycemia, than to not give a sugar source, have the blood sugar go too low, and end up with someone who is comatose and not getting the needed glucose to the brain. So I'd rather give them too much than not enough. So I always err on the side of, eat something, get some sugar into them, and then go from there if you can't check a blood sugar right away. We've spent a long time talking about insulin in the treatment of diabetes, but we also have medications that can be given orally to manage diabetes. These are typically used in the management of type 2 diabetes. Type 1 diabetics are going to require insulin. Their pancreas isn't producing it. We've got to give it to them. But type 2 diabetes, we have some other options that we can use. So oral diabetic medications can be used for people in conjunction with diet and exercise to help them get control of their blood sugar. But they really should be doing the diet and exercise piece along with it. And how they work, or specifically the ones we're going to talk about, are called insulin sensitizers. And what they do is they enhance the cell's response to insulin, so it allows glucose to be used more efficiently. The cells that we're talking about are those insulin receptor target cells, located heavily in the skeletal muscle, the liver, and the fat, or adipose tissue. So these three types of tissue have a lot of insulin target receptors on them. When we give an insulin sensitizer, it makes these tissues more sensitive to insulin. It does not stimulate insulin secretion, okay? What they're doing is they're activating receptors in the cells so that we can regulate insulin activity and make more efficient use of the insulin that is there. What this does, we use the insulin more efficiently, so then we're able to decrease the amount of glucose in the circulation. It requires that insulin is present in the body, and that's why we can use this with type 2 diabetics, but we can't use this in type 1 diabetics, because if insulin is not present in the body, the oral diabetic, anti-diabetic medications will not work. Commonly, the medications that you may be familiar with, that are oral anti-diabetics, and one of them was on your drug list, and that is Actose. So if someone is taking Actose, which is an insulin sensitizer, what are some of the adverse effects you may see of them? Commonly, most common, fluid retention and subsequent weight gain. So that's the most common ones we see with insulin sensitizers. Otherwise, you could see some headache and some fatigue and some diarrhea. Again, you may need to look at adjusting dosages and probably kicking in with the things such as losing weight and exercising, so that we can decrease the amount of the insulin sensitizer that the person is taking. With that, I will tell you, we have ended finally our series of discussions on medications that affect the endocrine system. So you'll want to go back through, review your notes, do your activities, and that before you take your quiz on the medications affecting the endocrine system. And then for next time, our next unit, we have another drug summaries for you to do. So once you've got everything complete on the endocrine unit, and before the end of the week, you will want to go and submit drug summaries on the list of medications that I have here. And that would include Valtrex, Levaquin, Atripla, Rocephin, Solodine, and Garamycin. And if you are familiar with any of these, you will realize that these are drugs that are all involved in the infection process. So that'll be our topic of our next module. Good luck.